And I'd like to really start off by just kind of going around the room and doing some introductions so that our presenters know really who's around the table with us. And we'll start with you, David, if we could, please.
Hello, my name is David Moran. I'm a physician at University Health at the Lakewood campus and the clinical director, or I should say the director of clinical informatics in the Department of Family Medicine.
Great, thanks, David. Anna, do you want to go ahead, please?
Sure, thanks. My name is Anna Hagenkord. I am a critical care nurse, but more importantly, I'm the leader of our care services at ModRN Health, which I'll talk about a little bit more today.
Thank you. Marie?
Hi, I'm Marie. I work for Illumisoft, which is a custom software company, and we work with medical researchers to create software solutions for any of their needs.
Great. Mallory?
Hello, I am Mallory Moon. I am a research project manager at Children's Mercy.
Great. Daniel?
Hi, I'm Daniel Kennedy. I'm the Vice President at BioNexus KC and the Director of Grants, of which we have one open for fetal and maternal health right now.
Great. Todd?
Hi, my name's Todd Ike. I'm with On and On. We do 3D mapping.
Great. Jeff?
Hi, Jeff Blackwood with New Frontier Mobile Diagnostics. We do quality, affordable, on-site mobile imaging.
Great. Thank you, Jeff. Linda?
I'm Linda Van Horn. I'm the founder and president of iShare Medical, and we are building a complete medical record organized around the person that's easily shared. We're a direct trust accredited trust anchor, and our network spans 1.8 million healthcare providers.
Great to see you again, Linda. Thanks. Anurag?
Good morning. My name is Anurag Patel. I'm founder of this company, as well as a environment for health data. I also help with the digital drive team in the health innovation team.
Great. Carissa?
Good morning, Carissa Hutchinson. I'm part of the ModRN Health team, so I'm just here to support Anna and help answer any questions that I can.
Great. Thank you for joining. Casey?
Good morning, I'm Casey Ross with Children's Mercy, and I am a research assistant that works on projects that promotes physical activity in adults and in children.
Great, welcome. Derek?
I am Derek. I head up a free and open source medical graphics software project. It's called Corpusum, and we use 3D interactive graphics to create immersive experiences inside the body at various scales, micro to macro anatomy.
Great. Steve?
Hi, I'm Steve Kropp. I direct the telehealth for the University of Kansas Health System.
Great, welcome. William?
Hi, I'm William Crumpler. I work as a program analyst with KC Digital Drive, doing work on both our digital inclusion and civic innovation work.
Great. Kapil?
It's Kapil Nair. Good morning, everyone. I'm with Batera Health. We do patient safety and quality management consulting.
Alfredo? Alfredo, you with us? We'll come back for Alfredo. Doug?
Yeah, I'm Doug Kohulin. I'm a volunteer faculty member for the KU School of Nursing, working on immersive technology and virtual reality for education, and also working on surgical navigation immersive technology as well.
Great. Teresa?
Hi, Teresa Gerard, independent healthcare consultant working on some advisory projects for community information exchanges.
Mike?
Yeah, hi, Mike Mitchell with Unite Us. We're a technology infrastructure company working to address social determinants of health and health equity by connecting government, health care providers, and community-based organizations.
Great, thank you, Mike. Matthew?
Hi, my name is Matthew Piecha. I'm with the Center for Practical Bioethics, and I'm the ethics lead on the Ethical AI Initiative.
Great. And that's an initiative that KC Digital Drive is participating in as well. I'm John Fitzpatrick. I have, in my private operations, I'm a consultant in digital health and also global strategic marketing. I have been helping to organize these meetings for more than 10 years now. And as I mentioned in the notification for this meeting, we'll actually be celebrating 10 years now with KC Digital Drive in November. So we look forward to seeing you all on November 5th for a dinner together to celebrate 10 years of activity and impact. I'd like to start out today's meeting looking at a very interesting critical care solution from ModRN Health. Our presenter today is Anna Hagenkord, the lead for that project at ModRN Health. And I'll just hand it to you, Anna, and look forward to hearing all your good story.
Awesome. Thank you so much. Let me just share my screen here.
I'll make sure that I've given it to you. Just a second here. Good.
Okay. Can everybody see me okay?
Yes.
Okay, well, thank you for your introduction, John, and having me today. My name is Anna Hagenkord. I am a critical care nurse and a part of our virtual care team at ModRN Health. And I'm going to give a brief overview of our virtual care services this morning. To start off with, we are a clinical provider to NETCCN, which is the National Emergency Tele-Critical Care Network. Along with partnering with NETCCN, one of our goals is to provide rapid response telehealth capabilities for areas across the country that might need it. So at ModRN Health, we really like to focus on providing a solid performing team that's managed by us. And this is one of the things that makes us unique and different from other competitors. It's also what provides us a distinct advantage for clients. And I'll talk a little bit more about that here in a second. We are distinguishable in the way that we provide services. Specifically, what we have found is that it's best to address the need of the hospital at the time we're providing services to them. Much of that today includes hospitals that have difficulty with delayed patient transfers. Many rural and critical access hospitals have been holding on to their acute patients for hours or even days due to level 1 trauma centers being full or on diversion. In this situation, ModRN Health's virtual clinicians can help walk that boots on the ground team through how they would care for these sick patients that they may not be used to stabilizing or even caring for at all. We also address this same situation.
Anna, I'm sorry to interrupt. Just to note that you're not quite on full presentation for the slides. We're seeing them, but we're also seeing your notes as well.
Okay, let's see.
There you go. That's great.
Okay, perfect. I apologize.
No, not a problem. Not a problem.
So we also address the same situation in a case where the boots on the ground team might lack experience or educational resources with higher acuity patients. Unfortunately, we're seeing that there's a nursing shortage across the country. And you can imagine how some of this expertise is also lost with the larger hospital groups of nurses leaving the bedside. So this is leaving some of our hospitals with their most experienced nurses maybe only having 3 years or 2 years of experience. And in that situation, who do those nurses turn to when they've never had, say, a septic patient, or their senior charge nurse is in a code across the hallway and their patient is struggling too. So obviously the staffing shortage is something that everybody's dealing with, and we aim to address this problem. Lack of experienced clinicians can be due to many things, but for lots of areas, even prior to the pandemic, it might only be that geographically that area is harder to staff. If you're a travel nurse and you're offered 2 contracts, one in Manhattan, Kansas, and one in Manhattan, New York, most of the time the nurses are going to take the ones in Manhattan, New York. Other reasons might be that they just haven't had certain patient experiences because their population just doesn't have those cases. And maybe that population is heavy with, say, heart failure patients, and they're really used to taking care of those types of patients, but they haven't taken care of, say, a cystic fibrosis kid in years due to the fact that their population just doesn't have cystic fibrosis kids. So that's another example. One specific hospital we provided support to did have experienced nurses of 10 to 15 years, but those nurses haven't performed a cardioversion in-house, which is a bedside procedure that those of you at KU would know it's a pretty regular thing for us to do. Just because they didn't have patients that had required a cardioversion in that long. And so in this situation, we were able to step in and help walk them through that process so they had more confidence while performing the procedure, and a second set of eyes on the patient for patient safety. So this was also helpful for their staffing situation and patient ratios, because instead of that patient requiring 4 nurses that are, boots on the ground nurses trying to figure out how to do this procedure, which they haven't done in a long time, it only took 1 boots on the ground nurse and 1 ModRN Health nurse to successfully make sure the patient was safe. Unfortunately, we're also seeing many rural and critical access hospitals closing their doors when funding is no longer there. So keeping these patients in-house allows the hospitals to keep their reimbursement dollars and prevents them from giving away premature transfers. So many other hospital telehealth services or tele-ICU services, they usually require pretty costly EMR or camera monitoring integration. And here at ModRN Health, we're really trying to be a part of the solution. So with that, to integrate us, it doesn't take much more than an iPad or a device that can hold any sort of application. And most hospitals already have iPads on units for things like translation services. Our way of doing things is pretty unique to the clinical world today. All of our clinicians are currently in practice, which I'm very passionate about. It's important to us that the expertise we're giving is the most current and up-to-date practice, and this is how we address that. As opposed to waiting on hold for our consultation team or calling back to a larger health systems hub, which many smaller health systems are doing today, our technology allows the providers to be on demand just with 1 click. There's no waiting time as you would normally see with ICU consults back to, say, larger health systems hubs where they're trying to get a hold of an ICU team who's taking care of their own patients. I touched a little bit on this earlier, but something we're also very passionate about is that we aim to integrate into the hospital's already existing culture. So none of our clinicians are there to step on any toes or tell people how things should be done. Our team has expertise in clinical practice, being preceptors and educators, charge nurses, and they're very flexible and adaptable to jumping into existing policy, procedures, and cultures of any situations that we step into. Because we're here to address the needs at hand, hospitals or health systems are able to sign the contract, start that day with us, and along with our monthly subscription model, it allows for extreme flexibility. So if you have a COVID surge and you need us that day, great, we're happy to jump in and we can start that day. If things slow down a bit and funding needs to be allocated somewhere else, you're able to cancel the subscription right then. So here you can see an example of what our clinician team would look like to step in virtually. Our on-demand model includes ICU nurses, respiratory therapists, and intensivists, but this is not exclusive. We also have pediatric nurses and pretty much every specialty. So with the lightweight software that we have, anyone can consult our team within minutes, however they prefer, meaning video, voice, or text. I know most recently I've seen a lot of the nurses prefer to text their questions. We're very busy people these days, nurses are. So sometimes it's easier for them to text, but it allows for all the options. And like I said, the software is downloadable and runs on any iOS, Android, phone, or tablet. So for our virtual care clinicians, we quote based off of hospital size and needs, but you can see here an example of what it would cost for, say, a 25-bed hospital looking for as needed 24-hour ICU coverage. And like I touched on earlier, we want to be a part of the solution, for these hospitals keeping their doors open for their communities. So we really are trying to make it as affordable as possible. And this can be even more flexible when several hospitals go in together for more of a shared resources model. Overall, I think many of us in healthcare share a lot of the same goals. So here at ModRN Health, we try to ask ourselves often, how do we best support our clinicians in order to do the best thing for the patient? And we're focused on just that, patient outcomes and how to really, truly make that difference. So I want to thank you all for your time and listening to my brief overview of our virtual care services here at ModRN Health. I apologize that everyone got to read all my notes. But here listed is my contact information if you want to reach out to get together, and I'll turn it back over to you, John, or anyone that might have questions.
Yes, that's great, Anna. Thank you so much. I guess my first question would be around the sort of lightness of the technology in the sense that it isn't really the dominant factor. It is the sort of the connective tissue, but it's not the dominant factor. Can you say a little bit more about how, for instance, the texting aspect might be used?
Yeah, absolutely. The software is, like I said, it's very light and easy to use. So you would consult on the software, pick out your patient, put in all the relevant information if you wanted to, or if you didn't want to, you can just text a question to the nurse. Say, we've had a lot of those specific situations where a nurse on site was not an ICU nurse and got floated to the ICU floor because they didn't have the staff for it. So that particular nurse had never used an A line before, an arterial line, which is something that's pretty typical or usual for an ICU nurse to work with. But she'd never used it before. So she was able to text us and say, hey, am I doing this right? She sent a photo later and we were able to say, yep, that's perfect. So they're able to use text if that's easier for them, video conferencing as well. And then it obviously keeps track of patient data as well.
So it is somewhat on demand according to the institution's subscription. Is that correct?
You got it. Our as opposed to saying calling back to a hospital hub where an ICU team is caring for their own patients and then they'll call you back as soon as they get a chance. Our team is available and on call and ready at all times. Pretty much this is what they're doing when they're providing support.
Are there state licensing considerations in this type of engagement?
It's a great question. Yes. What we found recently is many hospitals for telemedicine many states for telemedicine are actually doing exceptions for help with the pandemic. So depending on the state and their licensure laws, telemedicine is sometimes an exception, but a lot of our providers are licensed in many states as well to cover that.
Okay. And are they kind of dispersed? They themselves are also virtual in the sense that they're dispersed across the country or across the region or whatever?
Mm-hmm.
Okay. I would like to invite the others. Teresa, you have a question.
Yeah, thank you. Given that, potentially the public health emergency may end, are there certain capabilities that you will also have to pull back on and then just rely on, for instance, the nurse licensing compacts?
Yes, that's a great question. So a lot of times we rely on the nurse licensing compact. It's super helpful in general. Other times we are chasing licensure. So there are some states that are just fabulous and can kind of push out licensure within 2 weeks, and other states it takes a little bit longer. But we haven't seemed to have a problem. We do have a large bench of nurses, ICU nurses, who are ready to what we call deploy at any time with licensures all across the country. So if we have, say, a project that comes up in a state, on the East Coast, we have nurses that have licenses there, and I'll reach out to them individually, and usually they'll take that specific project. Does that answer your question?
Yes, thanks.
Great. Other questions from the team?
Hey, John, I had a question.
Yes, please.
Anna, this is good to see you again. There was something that you mentioned that I thought was pretty interesting. Your service with rural hospitals helps keep patients at those hospitals at times. That's great for continuity of care, but for the hospital, it's also great for revenue. Do you guys track that? Is there milestones or ROIs that you can generically talk about that would be interesting to us in the group? I think it's a great service to have that for them. And it's probably an easy way of them just saying yes to your service if you can show that.
Yeah, absolutely. It is something that we track, something that we're looking at for delaying premature transfers specifically. So we're seeing that many of these hospitals, if they haven't seen these capabilities or their physicians are like, oh, we'll probably have to transfer them out eventually anyway, let's just get them out now. We see those situations sometimes even with very low acuity patients, UTIs that they think might get septic later down the line. So we do keep track of acuity in that sense, and when they're transferred out, what we would call prematurely. And I agree with you. I think that's a very compelling point to some of those smaller rural access hospitals that are trying to keep their doors open.
Other questions? I have one that I might direct to Caressa. It's just really great for us to have a founder with us. So thank you for joining us today, Caressa. Maybe you'd like to say a little bit about kind of where you came from and how what problem you were trying to solve as you took off into this space.
Yeah, thanks for calling me out, John. Yeah, so I'm the founder of ModRN Health. Actually, since we're here to talk more about the this piece of it, I'll kind of just focus on that. So we're actually a virtual primary care and patient advocacy company. That's really where we got started, and that's our main service line. But this is a real continued need that we saw kind of pop up through COVID, and have just kind of realized that it's another way for us to be helpful, and it's very easy weight for us to kind of lift and help out quickly. With our core business, I was a nurse by background, worked in a level 1 trauma hospital, and really wanted to get doctors and nurses connected with the patient instead of in these kind of siloed systems. So what we do is actually sell through employers normally, and assign a nurse advocate and a primary care doctor to every employee. And then we also help them navigate the system. So we learn their insurance benefits, we learn financial resources that might be available, and we are available with that dedicated care team, 24/7. So it's never a cost to the patients. This came to us, and it was really, it was very close to my heart, because one of the reasons that I really wanted to get patients access directly with nurses and doctors was at the level 1 trauma hospital I served, we did have a lot of cystic fibrosis patients. And working in a big hospital system, I didn't realize really what all the things that were lacking in some of the rural systems. So I can say that there were several cystic fibrosis patients that I had taken care of for years, and then they would be traveling, or they would end up in a rural community hospital, and really no fault to the community hospital, but it was just a disease process they hadn't had much experience with, and we ended up losing several kids that way. And I thought, gosh, if they could have just called me, if the care team could have just reached out to us, we could have given them a couple pointers on, hey, this disease process is a little bit different than maybe a different lung disease process. And I think we could have had a really big impact. And I know that it broke the hearts of the care teams at those hospitals too, to just not have the expertise, because the heart of a nurse and physician, of course, is we want to save everyone, and we want to give the best care possible. But when you're in a rural community and you just don't see something very often, it gets outside of your skill set, and there's really, excuse me, no resources for those people. So when this kind of was brought to us during the COVID crisis time, and we were able to reach out to rural hospitals starting in Puerto Rico and really just empathize with the boots on the ground care team and really make an impact on, just walking them through the process of taking care of those patients and, finding ways to be able to help them. It was very satisfying for us. And now we've kind of taken that and realized there's lots of use cases for that. It does tie back to, that rural community and just having someone to keep those patients there. We don't want to see those hospitals close. They're closing in record numbers right now, and they absolutely, are necessary. So we don't want to see those lost in the community. And we're finding use cases now with long-term care facilities and with just the shortage of staffing that's happening across the country right now. You used to be able to maybe go grab a seasoned nurse down the hallway when you wanted to, make sure that you were doing the right thing as a new nurse too. And now suddenly everyone's got 10 patients and you can't just go grab a seasoned nurse down the hallway in real time. So for us to be able to hop on and just, empathetically walk through and our care team knowing what it's like to be that overwhelmed nurse on the, on the ground and being able to empathize with them and help them and educate them. We've even offered, like resources for the whole hospital where we come in and do education and webinars and it's fascinating how, it's not hard for us to get those clinicians engaged. They all are hungry for the education and hungry for the support. As you can imagine, during COVID, people were pulling out ventilators from the basement and saying, we've never used this before, but we can't transfer a patient out, so we have to figure it out. So to be able to kind of hold their hand was it's just really satisfying work for us. So we definitely want to continue that. And I guess I kind of mentioned the different use cases. I was going to tell you, Anna, maybe mention a couple of the different use cases that we've been playing with, but I think I rambled on and covered it.
No, it's great. It's a very compelling story, Carissa, and thank you very much for sharing. Anna, do you have any closing comments?
No, nothing specifically. Thank you, Carissa, for kind of wrapping things up. And, I think for a lot of us, like I said, we share a lot of the same goals, but patient advocacy is definitely the top of that. We want to see our patients do the best, and we want to see our providers supported in the way we can. So that's definitely our main goal there. And thank you for your time.
Well, thank you. We really appreciate it. It's a very exciting move and shows, I think, part of what a smaller organization is able to do is to pivot much more quickly. That kind of leaning into the COVID pandemic was something that was just necessary, and those companies that were able to do it made the difference. So congratulations on that, and thank you very much for sharing.
Yeah, thanks for having us, John.
Okay. A couple people have joined us, or we missed in introductions earlier, and I'd like to just give them a chance to say hello to the team. Is Alfredo with us? Alfredo may have gotten the call or something. Paul, are you with us?
Yeah, I'm here. Yeah, is there anything specific in the introduction that you want me to hit?
Just a brief introduction of yourself would be great.
Awesome. Well, my name is Paul Freeman. I'm currently working as a management consultant, specifically focused on healthcare technology. So I'm really excited to hear some of the stories like Anna's about what is out there and learn more.
Are you based in the Kansas City area?
Currently in Dallas, but moving to Kansas City in about a week.
Oh, great. Well, we welcome you here. We'll look forward to it.
Yeah. Thank you.
Please feel free to come back to our group at any time.
Absolutely.
Gary, could you say hello, please?
Hi, good morning. Yep, my name is Gary Carnes. I'm a nurse by trade and a telehealth program manager here over at the University of Kansas Health System. Thank you for having me today.
Yeah, great. So you're very welcome. Okay, let's move to our next presentation. This one I found out, KC Digital Drive has been involved with a project called Our Healthy Kansas City East Side, which is run by Dr. Jeanette Berkeley Patton from the University of Missouri, Kansas City Medical School, under a grant from Jackson County. And we learned through this of a very exciting program that Children's Mercy has been sponsoring, and they showed up at a number of the vaccination events that the Healthy KC Eastside hosted, and they made a study of the work they were doing to bring activity to the broader community. And we'll look forward to hearing from that today. Our presenter is Mallory Moon, who is a research associate with that program and Children's Mercy, and welcome Mallory.
Thank you. Good morning. I'm also going to share some slides, and while I get those pulled up, contrary to what you might assume about a children's hospital, we do care about adults. And so this program that I'm going to talk about today was a physical activity program for both children and adults in the community. And I'm also going to have a co-presenter who is Casey. So please let me know if you have any issues seeing my slides. My Children's Mercy laptop does not like Zoom very often, so we will do the best we can.
Looks good so far.
Great. So Active KC was an 8-week physical activity intervention where we provided a basic Garmin physical activity monitor and integrated it with some automated pre-written text messages that were customized for our participants based on their Garmin data. Okay, so what does that mean? What does that look like? Every participant received a Garmin physical activity monitor. It was a VivoFit 4. Our team set up their Garmin accounts and helped them connect their device to their Garmin account, which we found was very beneficial. We learned this from previous research studies that we've done using the same device. So we set up their account for them and connected that Garmin account to our API so we were able to access their data. We didn't receive their data in such real time that we were seeing it in 15-minute increments or even an hour, but we usually got that data about once or twice per day. And we were using Garmin for all the text messages that we were sending. We were using Garmin data from the previous few days to share those customized text messages. So we paired the Garmin API with a text message system that we built at Children's Mercy to send out about 5 text messages per week. So you'll see on the right side of the screen, that blue box, that's kind of the outline for the week of text messages. On Sunday, you'll see we reviewed the participants' past week. We reminded them of how many days they met their goal, how many steps they'd walked in the past week. Mondays and Thursdays, we provided behavior change topics. So because this was a physical activity program, we wanted to affect change in people's daily physical activity. And some of that we did through providing weekly topics to discuss with participants through the text messages, where we asked for, like, what did they value? Why were they wanting to be physically active? We had them respond to us on Mondays. And then that Thursday text message was just a reminder about what they had said, their answer from their Monday text message was. So just a reminder of why they found value in physical activity and encouragement to use those values to continue on their physical activity and health journey. On Wednesdays, we had a midweek check-in. So that would just remind them how many days they'd already met their goal for that week, their step goal, or how many days they had to go until they met their step goal for the week. And step goal, I'm saying that as if everybody knows what a step goal is, but the Garmin Activity Monitor sets goals per per participant. So it fluctuates based on a participant's daily steps. So it starts at a very low number, maybe 5,000 to 6,000 steps, and then builds or decreases depending on how many steps a person is getting every day or every week. We also sent a physical activity tip on Wednesdays. That's just let people know on how to integrate simple, easy physical activity into their everyday, like parking farther away at the grocery store or taking the stairs instead of elevators. Fridays, we sent milestone text messages where we created badges for participants based on the steps or length that they had walked throughout the entirety of the program. And we wanted it to be things that they could relate to. So some of our badges were, you walked from Kansas City to St. Louis over the course of the entire program, or from Arrowhead Stadium to Sporting KC Stadium. Then you'll see in the text message plan box that there's a icon of the watch. And that's where we piped in the Garmin data. So this is where the customization came in. So on Sunday, Wednesdays, and Fridays, we had the data from each participant piped into those messages to make them customized to each participant. But if we weren't getting any of their Garmin data, we couldn't send those customized messages. So every time you see a watch on the plan, if we didn't have data, we sent wear reminders. And those wear reminders just reminded people to put the watch on if they weren't wearing it, or to sync their watch to their device that they had their Garmin account on. So the research aims for this study were very formative. We were wanting to learn how to optimize an intervention for the population groups that we were targeting in this program. We wanted to learn about what participants like, what they didn't like, what additional services could be layered in, what we were missing, and what remaining barriers to being physically active participants were experiencing, as well as other kinds of supports that we could provide for our participants. And we were really interested in seeing how some of these preferences differed across the groups of participants, across ages, across adults only participants versus family participants versus child only participants. And in Active KC, we delivered the same content across all age groups, which we don't expect to be the best way to do this work. So we're hoping to learn more about the language content used in the text messages and the kind of supports that different age groups need or want to see. We got at these aims through the evaluation piece of community input received throughout the program. So in those text messages, not only did we send text messages, but we asked participants to respond to our Monday messages. So we were able to see what they were saying about the program, how they were engaging, if they were engaging at all throughout the program. We also hosted focus groups at mid-program when a participant was in the middle of their program, and then optional to attend a focus group at the end of their program. And then we also had quantitative and qualitative items on 2 surveys that we provided at baseline and post-intervention. So we had 183 enrolled participants, and like John mentioned earlier, a majority of our participants were enrolled at those our Healthy Kansas City Eastside community events. We had 159 complete the program, and then an 88% response rate for our post-intervention survey, which we're very happy with. And then over the course of the entire few months that we were hosting this program, we sent out over 10,000 SMS text messages. We hosted 8 focus groups with 33 attendees to discuss the perceptions of the program and ways that we could improve in the future. As you'll see, our mean age, when we say we want to impact change in in both kids and adults. We really mean it. We had a mean age of 13 and an adult, a youth mean age of about 13, and adult mean age of around 49 or 50. One really cool thing is our youngest participant was 8 and our oldest participant was 88. So we had a wide range of ages engaging in the program and engaging in our technology. You'll see that 83% of our participants were Black or African American, 14% were white, 1% Asian, 2% other. 3% of our participants identified as Hispanic or Latino, 18% were male, and 6% reported living with a disability. And from our focus groups, we'll talk about our themes now, what we're starting to figure out.
Okay, so excuse me, as mentioned earlier, we held 8 focus groups with our participants, and then we were able to kind of pull some reoccurring themes that came up in each focus group. This first theme, the program provided, we saw how the program provided helpful behavior strategies. So we looked at how the program provided motivation, monitoring, and tracking awareness that was provided by the Garmin text messages in the program overall. Some other areas that we looked at were goal setting and attainment, sense of accountability and accomplishment, and problem solving. This next program we looked at in the theme was how the program leads to beneficial outcomes. And we looked at how outcomes of the program and reasons for participating and benefits of the outcome of the program in general. So this could be if a participant said health is important to me. And then this next theme, we looked at how the program supports beneficial family and friend engagement, also coupled with support. So we looked at how social support is used in the program and how it is sought out by the participant. And then we also looked at how participants referred others to our program, and then also how they engaged in friendly competitions and how they interacted as a family. This next theme, we looked at how our program could be improved with additions or modifications. So we looked at how participants would improve our program with suggestions. This could be in the form of team activities, changes in our text messages, or just the duration of our program. We also looked at how participants would or would not recommend our program, and then if they would like or dislike our program. Now there are a couple of other themes that are not listed on the screen where we looked at how participants like the characteristics and functionality of the Garmin watch, and then also how participants felt our text messages and web link content was beneficial to them. Okay, and then some emerging lessons that were learned. Our participants truly enjoyed using the Garmin watch in the program, but we did notice that with some of our participants, there were mentions of how technology, the uses of trying to keep the watch synced and us being able to see their data. Our participants really enjoyed how the program was able to help with awareness and see how active they are throughout the 8 weeks. And it also helped keep them motivated. This was one of our most impactful parts of the program, as a lot of our participants really wished that our program lasted longer than the 8 weeks. They also enjoyed how we made the wording of our text messages and program materials overall inclusive, as some of our participants may have struggled with their weight, being physically active, or just having the motivation to try to form better habits when it comes to being physically active. Our program was a way for families to bond with one another and also support and motivate each other. A lot of our families in the program mentioned this, and they really enjoyed how they were able to challenge one another by helping meet their daily goals that were set by the Garmin watch. Now, while there are many aspects of our program that the participants enjoyed, there are some areas that we could improve on, with one being able to provide more personal and tailored contact. And as mentioned earlier, we sent out text messages through a text messaging system. So a lot of our participants wanted that more human contact. Quote that one of our participants said that it almost felt like they were talking to a robot. So just having more human interaction, and then also providing structured group activities, like I mentioned earlier. This could just be in the form as having group activities where our participants can interact with one another and other participants in the group. And then using more child-friendly messages for our youth participants, and then also just supporting a sense of community amongst the other participants in the program. And then here are some quotes that we pulled directly from our focus group. So these are some examples of feel and share. Now, I'm not going to read each quote verbatim, but I will kind of summarize what each quote is talking about. So this first quote, this participant really enjoyed how they were able to provide text messages and materials that made them feel good about participating in an inclusive environment, since fitness and health can be kind of a sensitive topic to talk about. The next quote, this participant really enjoyed the encouraging text messages that our program sent out every day, and particularly enjoyed the text that told them how many milestones were walked, or how many miles they've walked, like the milestones text messages that were mentioned earlier by Mallory. And then this next quote, this family really enjoyed being able to use the program as a way to bond as a family, because it made them closer in that regard and gave them something to talk about. And they also felt that this program came just in time, as COVID had a major impact on physical activity at some point of time. And then this next quote, the participant really wanted more tailored materials to them specifically as an individual, as it would help them be more engaged in the program. And then lastly, one of our participants really enjoyed how we really enjoyed if we were to incorporate like an 8-week exercise class to go along with our program. And then they kind of really wanted more of an in-person aspect of our program, because our program was virtual. So just having that more in-person contact with other participants and us as a program is really what they were kind of yearning for in our program. And then overall, our participants really enjoyed participating in Active KC, and we have gained a lot of insightful and valuable information that can be used in the future with other programs that are similar to Active KC.
And I will say that this is all very preliminary data analysis. We're still, as you can imagine, neck deep in a lot of data that we haven't even been able to touch yet. The program just ended last month. So we have all of the text message data that we're still looking to go through, final survey responses, as well as more in-depth analysis of our focus group data.
That's great. Thanks, Mallory and Casey. There's a bunch of exciting stuff here that I will comment on if I get a chance, but I'd first like to open it up to the group. And I know that Dr. Varan had a question. David, are you still with us?
Yeah, I'm here. I was just moving between screens. I'm curious as to how many of your patients have iPhones. When we survey our group, which is the same as your population, about 50% of them do. And those that have iPhones, we've enabled the physician dashboard that Apple has released. And therefore, we can track the activity data without any cost to us or the patient if they choose to turn on sharing with their physician. And that's been quite exciting and patient engaging for a lot of the patients, because it's easy to do and it doesn't require any intervention.
Yeah, that's a great point. I don't think we tracked specifically iPhone versus Android. I know that a lot of our users are Android users, but it was a requirement to have a smart device of some sort because they had to download the Garmin app to be able to connect to our API for us to receive their data. But yeah, I don't know. I don't know specifically how many have that iPhone. We have talked a lot about the health app and how we could potentially eventually integrate that into some of the work that we do.
Thanks. Teresa.
Great, thanks. Yeah, I've got a couple questions. Did you work with Garmin on this particular project?
Yes, so we partner with Garmin regularly. They help provide watches for us and for our participants. So we don't work with them specifically for every single project, but we do partner with them on that API, getting the data and getting everything set up if we run into some hairy situations that we're not used to.
Now, do the participants get to keep the watches after the end of the study?
Yes, they do. That was part of their incentive. So they receive the watch and they get to keep it. And we also hope that this promotes like sustainability and habits that were set throughout the 8 weeks of the program. So they don't have to return the watch to us. They can keep track of their activity in the future.
Excellent. And do you know the 24 people that kind of dropped out that didn't complete the program, do you know some of the reasons why?
Yeah, so some of them were just understandably annoyed with getting 5 text messages a week. People are busy and we're constantly subject to notifications. So some people were just tired of receiving that input. They'd had enough. And some people were really struggling with their connectivity. Like I mentioned, having a smart device was a requirement of the program, but all of these smart devices have different operating systems, different settings that we can't necessarily account for. We do the best we can in getting their devices set up on their watches set up on their device. But sometimes it just didn't work. We tried everything. We tried all the Bluetooth settings, all of the app settings, and we just couldn't get it to connect. So they decided to like drop out of the program overall. And then some people are just general lost to follow-ups. They never engage with any of the text messages, or they don't respond to any of our final survey requests, things like that.
Great. Yeah, last question. Have you worked with, like, say, the YMCA at all, Linwood, for the in-person sessions?
So we didn't do in-person sessions for this program. We are talking about future integrations of that, because we are hearing from participants that they do want more in-person touches. We did a study in the fall of 2020 when schools had gone virtual, that it was similar to Active KC, but it was just in elementary school students, where we did virtual physical activity breaks. What we did is we came into a classroom and provided 10-minute physical activities for the kids in that class, and to give teachers a break. And that worked out really well, but we haven't partnered with any YMCAs or the Linwood YMCA for this piece yet. Great questions, thank you.
Other questions? Go ahead, Doug, please.
Yeah, so I'm hearing that the Elysian rumors that the Apple Watch may be giving blood glucose levels as well as blood pressure coming out. And so one question is if you had that data, do you think that would be helpful? What are your thoughts?
Potentially, there's a lot of, in research, there's a lot of things that we have to get approval for. So it would depend on some of our oversight if we could access that data, and on what participants are comfortable sharing with us. So
yeah, I know
it could be useful in some of the information that we collect, but we are really just trying to do behavior. So what is encouraging, what's motivating people to get out and get moving, and sometimes that is their health, right? So sometimes it's their diabetes or their cholesterol levels. They've been told by a doctor that they need to get moving, so some of that like health data could be useful in the future, but we were unable to incorporate some of those specific things for this one.
Right. And right now they don't have that, but especially someone who has diabetes and is testing every day. You know, I'm just thinking that if you don't have to get stuck every day, that could be a benefit, especially to the elderly. And then the other thing is the Apple Watch, you know, does have 5G connectivity. In fact, I have a family member who has diabetes, and my plan is to get that person an Apple Watch with 5G. Fortunately, there's a plan where it's only $2 a month incremental to add that Apple Watch to it. So as soon as it has blood sugar, and especially if it has blood sugar, that I think that would be a benefit. So, you know, from a Bluetooth, trying to get the connectivity and everything, if you can just give a watch that has the 5G cellular connectivity, so you don't have to deal with any Wi-Fi issues, connectivity to the cell phone and so forth, that may be a benefit as well.
Yeah, that's a great point. Apple's doing a lot of really cool stuff in the health space right now. I will say one main reason that we chose to not incorporate other smart devices that participants may have already owned is because of the text message customization and piping in data. So Garmin, we already have a great relationship with Garmin and their API, and we were able to connect our two systems to be able to send those customized text messages. So that's one thing. It's trying to figure out how to get the Apple data is a challenge sometimes, and from other devices like Fitbit and other smart devices that are out there. There's a ton on the market right now.
Do you know if Garmin is considering blood glucose?
I don't know. Yeah,
Okay.
I don't know.
Or blood pressure. Yeah, I think those two could be pretty powerful for people, especially the elderly. Maybe something.
Yeah, for sure.
Other thoughts?
I've got a question for you, Mallory. So with our virtual primary care and patient advocacy side, we're obsessed with engagement and human behavior, because none of that matters if we don't have a relationship with the patient. If they're not actively reaching out to us and feeling comfortable with us, we can have cool tools and it's hard, to make them actually effective. So my thoughts are just curious as to, we bring a lot of those data points in ourselves. But we have to buffer that with a personal relationship between the doctor and nurse to really make it effective. If you could talk just a little bit about what was the criteria to really consider a patient like engaged? Was it that Monday text back, or how did you kind of measure engagement? And then, what was the kind of points to consider a patient to have completed the program?
So that's a great question. Engagement is always really a fun thing to try to measure. So we were looking at the responses of the Monday messages. We also were looking at whether or not they were wearing their watch. So we incentivized wearing the watch. For every day that a participant wore the watch, they received $1. And so we were looking at how often or how many days out of the program they were wearing and syncing their watch. We also looked at whether or not they engaged us at any point. So we had not just the Monday message, but they could send a help text saying, something's not working, and so I need you to call me to talk about what's not working. And then the post-intervention survey, if they completed that, as well as engagement in the focus groups, if they responded to any of our invitations to join those focus groups or not. So we were tracking as much information as we could possibly get to those times that we were doing, like the human touch, the reach out, the trying to connect with participants.
Okay. Was that help reach out usually more of a technology focused question?
It was. Sometimes we had just like general program questions. Like I remember one participant sent the help text because they were noticing like the app was using a lot of their data. They felt like the app was using a lot of their data, so they just wanted to talk through that and how to maybe change some settings on their phone. But it was a lot of technology, yeah.
Thank you.
Yeah.
Did you have any behavioral coaching or any of that sort of thing at hand for any of those responses to people?
We had a automated response to the Monday messages, depending on how they answered. So for example, we had a value module. So week 2, we were, our Monday message was all about the participants' values and being physically active. And so we had a range of responses that they could get. So we didn't do free text responses. We had a list of values that they could choose from to text us back. And then depending on their answer, there was an automated response to that. We didn't have like any time, we didn't have a need to do any behavior change in person to talking about the technology pieces or anything like that though.
Right, I'm just wondering if maybe as you identified the need for some more personal touches and maybe some of that kind of nudging or personal coaching or those kinds of things could maybe be handled by, say, community health workers or something. Is that thought in your mind?
Oh yeah, we are definitely looking to see how we can partner with other groups that were involved in the Our Healthy Kansas City East Side project. And we're hoping to build out some future iterations, obviously depending on capacity of everybody. I know people are maxed out these days, but trying to engage community groups as well.
Yeah, I'm just was very excited when I first heard this presentation because it touches on so many things that seem to me over the years in my experience of being absolutely vital. And that was that you, rather than waiting for the community to come to you, you went to the community. So you kind of went to where people actually are to be able to begin that engagement. And those pop-ups really seem to have worked. Also, I've always been kind of a fan of the lowly text message, you know, just how powerful it can be. You know, it seems to be the simplest version of technology out there, but it does reach over distance and it does reach over time, and it really does can make a very big difference. Another thing I was really excited to see was that whole families participated. That's remarkable. And I just, I think that's an amazing piece of it. And then the other thing that I really thought was outstanding was the attention to the language being used. I think particularly as that Our Healthy KC East Side project progresses, that need for being able to have culturally sensitive language and situationally sensitive language will make all the difference. And the fact that there's already people paying attention to that is really, really important. So I think that's a tremendous value for the program.
Don't block me.
Do you mind, John?
Yes. Yeah, go ahead, please.
Yeah, I was just wondering how people texted back. They didn't do it through the Garmin device. They went to the app, right?
So we built a text message system at Children's Mercy using Azure, and we sent SMS text messages directly to their phone. So they provided their phone number to us whenever they were signing up for the program, and we texted directly to their phone, and they were able to respond on their phone, and it came through our system. Unfortunately, because of the time constraints from idea to launch of this program, we weren't able to build in the two-way like chat function of a text message. So we were just relying on those short responses that we predetermined for participants.
I have a question. I'll direct this to Casey. Casey, you were describing the themes that came out of the program. what kind of impressed you the most about the findings?
I would say, I think the family engagement and then also just the behavior change. I mean, a lot of our participants really enjoyed that aspect on how it got them motivated, especially with, you know, during COVID. A lot of us were quarantined. A lot of us weren't actually, you know, going to the gym or going out to get walks, so things of that nature. So I think that kind of really stuck out the most. And because what the things that we were looking at in behavior change, I kind of named a few, but there were a lot more aspects that we were looking at as well. And also that was kind of one of our biggest themes where we kind of got a lot of valuable information from our participants that can kind of help us scale up our program in the future.
Oh, that's great. I'd like to open it up to any other thoughts or questions. Okay, well, then let's leave it at that. Thank you so much, Mallory and Casey. That, as I said, there's just so many aspects of this program. Even though it was a compact sort of program, it really highlighted so many important things that I think the digital health marketplace really needs to pay attention to and know about. So your sharing it with us is very welcome. So thank you.
Thank you for having us.
Okay. Well, I will stop our recording here, but and invite all of you back next month. We're still looking to fill our slots for next month. So if anybody has any good ideas for how we might do that, I welcome that. Please reach out to me. I'm happy to discuss and see what might we put up for the next time. So with that, we'll say goodbye and thank you all for your time and your commitment.